cases where it's just like, hey, C-spine kind of goes out the window. You have to manage, because if they aren't breathing, if they're apneic, that's the kind of stuff that you have to take over and do. But backing up and not using life over limb on this, what would you guys do to first thing? Like, what's your first thought process on trying to manage this?
So this guy, you said alert, and he's feeling everything, and he's talking?
He was, and then now he just stopped breathing.
No.
So respiratory drive gone.
So he was able to move air in and out with his neck in that position previously.
Right.
So then are we going to try and manage his airway with just a BVM, or are we going to be able to use our laryngoscope to open that up and see the trachea and kind of move it around the bend?
I think if he already had his airway, he was moving air through, and then he just stopped breathing, he could have severed his phrenic nerve. So it could have, his diaphragm isn't working anymore. So I would try and ventilate and see if that
With a BVM or with a tube?
Is airway the only problem?
Airway is the only problem. Yes.
But if the airway
The only problem for you to manage right now. There's a lot of other problems, but for us, we're
bleeding profusely?
no. For this, we're stuck on airway.
Okay.
Right? We're stuck on airway with this guy. And so, is there an absolute right answer to manage this? No, there's not. This is one of those ones where you're going to use all your knowledge and thoughts and techniques and tools that we have, and you're just going to start at the beginning, and you're going to work your way down your list. I would start trying to bag this person. I'd start off with that. Simple adjuncts, right? OPAs, FPAs. Start there. That doesn't work, be like, okay, all right, let's try, see what I can do with the laryngoscope. Having somebody hold to make sure that as I'm lifting and moving and pulling, I'm not popping things back into place, right? And then what's another good, easy thing that we have to do very little manipulation to use?
King.
King, right? We could drop a king probably in this guy fairly easily, as long as things are fairly intact. But if he was moving air beforehand, probably means that everything basically from here to here is probably intact, and it's all probably posterior trauma. Does that make sense?
Yeah.
So as you work through these kind of weird ideas, weird scenario things, just start at the beginning and just start going down your checklist, just like any other patient. Just because somebody looks crazy and you have that shock and awe factor with somebody, be like, oh, okay, whew. All right, let's start with BLS stuff. Let's work our way through our BLS, simple adjuncts, and then go from there. It's very common where somebody will walk up on a call and be like, hey, we need to intubate this person. All right, let's get the RSI stuff ready. Let's get all this stuff ready. And then they go immediately and start drawing up drugs. It's like, hey, so do we forget like the first 10 steps of our process, right? Like getting your BVM and all your basic stuff taken care of, all right? All right, so the spine, so just a quick anatomy review. You got your 33 bones, 7, 12, 5, 5, 4. Yeah?
Yeah.
All right, so where do the nerves run when it comes to your spine? Because the nerves are what are the big things that are going to show us where injury patterns are, where it's hurt, right?
It depends where in the body. I think like starting with your legs, they actually come out in the lumbar region, motor and sensory.
So do all
Not all.
the nerves?
No, not all.
Oh, okay.
They all come out in different spots depending on where on the body they are.
Right. So are all the nerves protected by the spinous process?
At one point in time, they are.
Spinal cord.
They branch out from the spine.
Right.
From the spine.
Are there any nerves that come down out the distal end? What was that? Okay. So you're going to have nerves that shoot off all the way down, right? Do you guys have any sort of idea, memorization on how you remember what nerves are affected at what level of the body?
Dermatome or myotome.
Right, but like how do you have like a, hey, if they're paralyzed from here down, that's probably roughly T10. That's roughly T4. That's a C7. Do you guys have any sort of idea to try and figure out where the injury pattern could potentially be based on paralysis, nothing like that?
I did an A&P, but I've lost it.
Right. All right, so here in a little bit, I'll give you guys a couple quick cheat things that's going to show you kind of where they're kind of funny-ish, but it's a very common ones that we use in the field. All right. All right, you guys remember all your sections of the spine, right? What are they?
Cervical, thoracic, lumbar, sacrum.
What's the most prominent anatomical location when you're referring to the spine? When it comes to differentiating where, when you're palpating your spine, okay? Which one though? Which is the most common, prominent anatomical location to kind of give you direction of travel of where you are?
C7?
C7, right? C7 is the big knot on the back, right? So if you go like that, you got your big one that sticks right off the back. That is your C7, right? So that is our landmark where we start and be like, okay, we're still in our cervical area. We're going to run up. Okay, now this is all cervical. Everything else below that, we start running into our thoracic. So obviously, not all vertebral bodies are the same, right? What's C1 and C2 called?
Atlas and axis.
So how are those different than all the other ones?
They pivot your head, and then right where the pons meets.
So let's just talk about the structure first, okay? So you talked about it allows you to do this, right? Pivoting, moving around, all that kind of stuff, right? Move side to side. Are they anchored together with anything, or do they just kind of sit on each other?
There's a tendon that wraps around the back. The
I can't
tendon.
remember what it's called, but the
Meninges?
atlas basically has the bone that goes up through.
Oh, that's right. What Chandler
axis
said.
One that allows it to pivot around.
And it kind of sits on top of it,
Sits on top of it.
and it uses that to kind of spin around, right? So it keeps it from offsetting, right? So what would happen if you snapped off that bone?
Your head would offset.
Oh,
I
that's
don't
the
know if you would die
internal,
because you have an amazing paramedic.
decapitation.
Oh.
What'd you
So,
Internal decapitation.
internal decapitation. Big terminology, get thrown out. So, would this person die?
It depends on.
Depends on what?
On what else
It
happened.
depends on.
What's damaged underneath?
Go ahead, take a look in the mirror. It depends on.
On the paramedic they
on the
have on
paramedic
scene.
that's there. Right? So that we talked about, yeah, being good, being not good. Like I want the good paramedic. If it's after, right?
It's the
Yeah.
little,
It's a little.
the dens.
Yeah, basically what's it called?
The dens.
Dens, right? So basically the thing that prevents the atlas and axis from going like this, keeps it in place. So you snap that off. Now this can basically slide back and forth, and it can end up with cord injury. All right. Where does the spinal cord run on these?
Down your spine.
Does it run through here?
No.
Does it run through here?
Yes.
Yes. Yeah, I saw that there. Right. So this is where your spinal cord runs, right? Is everybody's the same?
No.
Is everybody's the same size, width, diameter? Or do some people have spinal stenosis? You guys have heard of spinal stenosis, right? Basically the narrowing around here, right? People can end up with bone spurs in here. This is where the people have chronic back pain, have to go in, have things beveled out. Anytime you're beveling out these, right? What are you working around?
All the nerves.
All those nerves, right? Is there going to be inflammation probably around it already?
Yeah.
So are those like piece of cake surgeries?
No.
Is that why neurologists make buku bucks? Right? And so
They act like it too.
So your spinal cord runs through here. Oh, not through there. Well, I guess it doesn't run there. So your spinal cord runs through here, right? You notice that the different types of bony structures, right? The farther down you get, the more heavy duty they get. They're going to get wider. Your vertebral body's going to get thicker, right? Because as your lumbar, it takes majority of the weight, right? It's a lot harder to fracture those. Where do we normally fracture? What are the most common fractures?
In the cervical spine?
Why in the cervical spine?
Because they're not as thick.
Yes.
Average
So
head weighs 8 pounds.
What'd you
notice down
say?
here,
The
we have
weight
all
of
our
that.
lumbars, right? They're big, giant, well, bigger spinous vertebrae, right? And then up here, you got your smaller ones, right? But we have this giant head. Down here, we have a bunch of muscles and everything. We're pretty limited, some of us are limited, on the mobility in our torso, right? So at the head, it has a whole bunch more and a lot more weight on a lot smaller bony processes, right? So it's very common for upper cervical fractures before anything, okay? The other thing with your cervicals is there more motion and flexibility to be able to move, right? So you have a lot more different directions of travel that it gives you a little buffer, a little give before the injury actually occurs. How about if you go like side to side at your lumbar or one of those, do you have as far to travel before you meet resistance? No, right? All right, so a little review here. What's this called over here? Gotta start the back first.
Spinous process.
Let me get you that. All right, so you got your spinous process, your transverse process. Oh, here we go. There. All right, so you got your transverse process and your spinous process here, right? So this is the one on C7 that you can feel back there, okay? So when we're looking for step-offs and deformities, that's what we're doing. We're running along the spinous process, and what we're looking for is for it to bulge out in a place that normally wouldn't be bulgy, right? So you're looking for those very distinct offset locations as you run midline. Is everybody midline?
No.
Do some people have a little curve in their spine? Is that deformity?
No.
Do you note that and be like, oh, geez, this person's totally jacked up and they're paralyzed because their spine does this all the way down? No, right? But is it something that you're like, I need to do a better assessment to see and palpate and figure out if there's crepitus and be like, oh, okay, it seems like a normal kind of a thing, but now I got some deformity in there as well, right? So now it's like, okay, now we're back to, yes, this is a potential injury, all right? So if you end up with fractures here, where do you think the most common place for the fractures is located?
Yeah, the lamina. Or the spine.
Does it depend on what type of injury, what type of trauma, force there is? Right? So depending on the fracture, or depending on the type of injury, if you have neurological deficits, probably one of the most common fractures is going to be right along here, okay? Because what's going to happen is this has the potential to fracture, and if this fractures all the way through, what does this potential do in here?
Squeeze on the spinal cord.
Yeah, this has the potential to fracture this way, and then this has the potential to shift in a little bit and put pressure on your spinal cord, okay? If you have paralysis, is there always a fracture?
No, sometimes it's just swelling. It's pushing on the spinal cord.
Can you have let's see, can you have complete intact muscles, intact, or bones, intact everything, and still have somebody that's paralyzed?
Yes.
Yeah?
Meningitis is one.
Oh, we're going with trauma.
Okay, well.
Eliminate with good, good. We're in the trauma section right now, okay? So,
Are you also not counting any sort of dislocation?
no, that counts as trauma.
My brother had 2 spinal that.
Was he did he
Yep, he ended up being paralyzed from the neck down.
full time?
Well, there was
Full time, like permanent?
he was paralyzed for 10 years.
So I have a friend that fell off a ladder. He fractured his back and is paralyzed basically one nipple across, right? But it's kind of a diagonal thing, but there was no spinal cord involvement. He did fracture his back, but there was no spinal cord at all. No spinal cord severance, no spinal cord, it was all completely intact. But what happened is the fracture put pressure on it, which caused edema, which caused paralysis, and then the surgeon didn't go in and fix it until the next day. And so then they had neurological death of the spinal cord because the spinal cord was partially clamped from those bones. And so they relieved all the pressure, spinal cord's totally intact, all the nerves are totally intact, but he's still paralyzed from it. So they talk about the neurological insult that happens to the spinal cord and stuff, contusions, stuff like that, can cause permanent damage, right? Without any sort of severing of the spinal cord or anything like that.
Did he win a lawsuit?
What's that?
Did he win a lawsuit against the surgeon?
No, he's too good of a person to, it's like, hey, things happen and that's what happens, so, yeah. You should ask Derek about it, because Derek, Derek and I both, yeah, he's a buddy of both of ours. We used to work with him for a long time. Probably the best paramedic I've ever worked with. Like, I was really hoping that he'd, like, become a teacher or something like that, like, because, yeah, he's super smart dude, so. All right, okay. So can you end up with a fracture here completely, or both of those fracture? Can it be totally stable with no neurological deficits? Yeah, because if this just fractures off here and moves posterior,
And there's no
there's
pressure on the nerves.
nothing messing with it, right? So what happens if you go through doing a great job being a paramedic and start palpating?
And then you push on.
Oh, you just paralyzed him. Good job. Congratulations. Now what? Ugh. You guys are good paramedics, right? So you palpate everything.
Yeah. You use caution in your palpation, and you would most likely start to feel pain before that spot and tenderness around
right?
it.
Because
So
anytime there's a fracture, what does that cause usually?
edema and swelling.
Edema and inflammation, right? Most of the time, if you fracture one of these, would it be pretty hard to fracture a single spinous process?
Yeah.
How many do you normally get when you have a fracture?
2 to 3, 5.
So roughly 2 to 3 at a minimum, right? Depending on depending on the type of trauma that there is. But yeah, you're gonna get a couple of them, right? Can you snap it off here completely?
Yeah.
Is that gonna cause paralysis?
Possibly. Depends on what trauma
Most
affected
likely
it.
not. But if you snap this off completely, what does this become now?
Now that,
It's like a free floater, right? It's a free floater that can basically float around. And if you think about it, that you have your spinal cord with all your nerves floating around there, who knows where that's going to end up, right? And so, majority of the time, it's not going to become a free floater because you have enough muscles, ligaments, and tendons in there to hold everything kind of in place. But as you palpate, you're definitely going to get some sort of reaction as you go down there, okay? And so, a lot of times what I like to do is as I'm doing my palpation, instead of running straight midline down the spinous process, I'll come down and I'll try and split it with my thumbs. And so the spinous process is right between my thumbs, and I'll run along the side, right? So what I'm doing is I'm able to tell if everything's midline, I can run down it, palpate, 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 all the way down, and then when I meet tenderness, I'll kind of push from side to side a little bit, right? To see stability before I push on the spinous process, right? You guys know what pinpoint tenderness is?
Very
where you can
localized.
feel where you can,
So if I say, hey, you got somebody in the car, and they have pinpoint tenderness on C4 and 5.
It's incredibly localized.
Okay?
I know exactly where it's at.
Oh, you got a smile there. There we go. Okay, so pinpoint tenderness C4 or 5. Big deal? Rapid C-spine?
yeah.
C-spine, long backboard, boom, out they come.
Yes.
If they're conscious, yes?
Yeah.
I don't know if you know
Do we do anything else? Do we consider anything else? Are we still in this rapid, hey, let's put them on the backboard, rapid C-spine removal?
If they're stable.
Anti-inflammatory?
They're stable.
Well, full CMS.
Okay, yeah, good. CMS, you got some numbness in the legs. They can feel a little bit, but they got some tingling, numbness in the legs. Kind of maybe even some tingling in their arms.
So are we thinking more so we already have pinpoint, we have tingling, so we need to move a little bit faster because we're expecting to have further edema, further swelling that can cause further damage. And right now what we're seeing is our new baseline, and the faster we go to get them to a CT to further evaluate the damage, the more likely we are to lessen that.
Long story short, no.
Great.
Okay. So with this, anytime you have anybody with pinpoint tenor, it's like boom, you're pushing on it and they're like ow, ow, ow. You're like, ooh. It's like, okay. Move around it, nothing, come back to that, ow, ow, ow. It's like, okay. So now everything goes from, hey, let's get him out to, right? And now you're slow motion. Everything goes a lot, because they have minor paralysis or minor numbness stuff. What do you not want to do?
Make it worse.
You don't want to make that worse, right? So if you got somebody sitting in the car and they're like, hey, I can't really feel my legs very well, got some grip issues, right? Because you guys did an awesome job in neuros, and now you're like, okay, yeah, let's put you on, let's put a seat collar on, let's spin you around here, and let's lay you down and do this whole thing as you bring you out of the car, right? Because it's always super perfect and super in line with mobilization, right?
Mm-hmm.
Yeah, 100%.
So what tool do we have that would be
KED.
the perfect opportunity here?
KED.
KEDs are totally underutilized in patients with neck pain, right? And when I say underutilized, we all know, like, so C-spine's kind of a thing of the past where we C-spine everybody, right? We're trying not to C-spine everybody. But somebody that has neurodeficits and pinpoint tenderness, you got to C-spine those people, right? Because what happens if they stand up, like get out of the car, self-extricate like they say we can, if they say it's going to make things worse, right? They stand up, boom, and then they go to turn their body, they turn the wrong way, and then now all of a sudden you had a bony fragment up in your C3-4 area that now they moved just right, and now you sever a cord, right?
Yeah.
Or you damage a cord, and boom, now they're fully paralyzed.
Or in that case, phrenic and diaphragm injuries.
Oh, dang it. So what happens with phrenic and diaphragm injuries? What does that mean for you guys?
Control
Airway.
Airway, we're back to that airway thing, right? So the cervical vertebrae, those are a big deal for us. Like, that is what we are concerned about of all the things, right? Paralysis down here, there's nothing we can do about that, right? Yeah, if somebody ends up in neurogenic shock, we kind of manage that. But the cervical vertebrae is what we are concerned about when it comes to moving and taking care of people, yeah? All right.
If you palpate sensitivity on their spine, when you backboard them, do you want to just pad that specific area, or are you worried that you're going to apply padding and it's going to push
So anytime you pad, what is the goal of your padding?
comfort?
Prevent movement.
Provide some soft support.
So we have the void thing, right? We talk about filling the voids, right? The lower lumbar area. Half the time, it cracks me up when people say, "Hey, I'm gonna pad as needed," and then you watch people legitimately pad somebody. I'm like, "What in the heck are you padding?" Like they're like, "Oh, we're filling in here." I'm like, "Yeah, you're filling in the void so your straps will fit better, right?" That's what it sure looks like. I was like, the padding is ideally so the straps will fit, but it's for the position and comfort, right? It's to keep people comfortable on those boards, because what's the potential that this person could be on the board for a long time?
They will be.
Especially
If they are legitimately injured, they could be on the board for a long time, right? So what happens if you have somebody with a spinous process that is pushing directly on the hard backboard?
It's gonna make it
pushing
worse.
directly on their spine.
Where's it gonna push? Oh, I took that picture away. Oop, where'd it go? Where is it gonna push? If this is pushing on the backboard right here, right? If you have damage there, it's just gonna push it straight in, right? Put pressure on that spinal cord. So putting as much padding really as you can up underneath there, while still maintaining the firmness, is gonna be what you're going for. Okay, so you're gonna pad it. So I don't know. Does anybody know about the body burritos?
I was just gonna say, how often do you use those?
Oh, those things are amazing, especially with little old ladies. The only bad thing with those body burritos, so for starters, does everybody know what a body burrito is? Anybody not know?
Huge earth.
All right, cool. So yeah, the only bad thing with body burritos is what happens once you get them on, right? like you can't get access to the arms and stuff very easily unless you like get them pulled out beforehand, but then now you got their arms out and now it doesn't really work as well. So there's pros and cons to them. What we started doing in what Lifeline or Reach, one of them, I started doing is putting these little air
Back rafts?
yeah, on the back of the backboards, and then, so I watch people and they'll totally inflate them all the way up, right? That's not the idea. You're putting just enough air in them to be able to take that pressure off of the spinous process, right? So just enough pressure, not fully lift them up like they're on an air mattress kind of thing.
Aren't they attached to the backboard?
Yeah, yeah. And so what we started doing for a while is we started putting foam pads and just taping foam pads onto our backboards. And then they realized that after like a week of that, and then they get ripped off and they never get put back on. They're like, okay, well let's try to figure something different out. And so I personally like the back rafts.
Back rafts, yeah.
Back rafts.
Really
I
cool.
like those because you can inflate them just enough just to take the pressure off. But you guys got to be thinking paramedics and realize, no, we're not trying to flow it completely up like you would with an air mattress and be like, get out in the water and then realize, oh, hey, we've got a hole in our thing and we're sinking now, right? And so you inflate it just enough, take that pressure off that spinous process, and keep that person comfortable. Okay?
Is that just if you palpate a sinus process that's broken, or are you doing that for all backboards now?
So ultimately, all backboards get it with the idea of that's what you're trying to accomplish. You're trying to avoid bony processes shoving into the backboard and causing further injury or discomfort. Okay? Okay, I got that. Oh, there's our dens right there. See it right there? There's our little.
There it is.
There's our
Give me a thumbs up.
internal decapitation leverage device. Okay, so we got those. Nice process.
Okay, little turtle head.
And then
Okay, so take a look down here at your lumbar and your sacrum, right? So you have your sacrum, right? Anybody ever broken their tailbone?
I bruised it really, really bad.
So I didn't ask if you bruised.
I didn't know.
No, but thank you, Noah. Just so everybody knows, Noah has bruised his tailbone. How about a fractured coccyx? Not comfortable, right? Okay, thank God. I mean, I've never had it happen, but I have only heard horror stories about the discomfort and the ring of, what do they call it? The ring of fire pad. Ring of shame. There you go. Yes.
It took me a year before I could just sit down and not have to like, it hurt. It hurt every time.
So, when you look down at the coccyx, how are those bones like really connected?
They're
Right?
fused
Are they-
together.
So is it one big giant bone that,
Yeah.
so you can snap it off at any point, right? So what's the most common way to fracture these?
Falling.
Falling on your hind end, right?
Roller derby.
Roller derby. Oh, roller derby. Yeah. Skiing is a very. Oh man. But how about walking on the ice? Walking, slipping, right? If you don't break your arms trying to catch yourself, you're gonna break your hind end as you hit, right? So does it take a lot of force to fracture your coccyx?
Not a whole lot.
No, not a whole lot. There's not a lot of protection there. How about down here in your sacrum?
It's going to take more force.
It's completely surrounded and protected, and it's one giant fused bone, right? So it takes so if you break something in your sacrum area, lots of force.
Yes.
Yeah. So if anybody ever tells you they're like, hey, you know, I have a fractured sacrum, and you're like, oh, how did that happen? And yeah, listen to the story because I'm sure it's going to be a pretty crazy mechanism behind it. How about your lumbar? Easy to fracture your lumbars. What's the most common lumbar fracture?
Compression.
Compression, right? So what types of patients are you going to see these in?
Falls, where they land on their feet.
Power lifters.
Okay?
Go back to the name on the board then.
Do what? Are we going back to the name on the board? Okay.
Come on, that was a good one.
No, the front and center. Here we go.
Maybe the class are doing the best on that one.
We just need to
Everybody.
figure out the right way to, I think maybe just like 2 joules per name.
Oh,
So for every,
I'm screwed.
for every tally mark you get, it adds 2 joules. Just becomes.
At the end of the class.
No, and I. No, and I.
Okay, so lumbar, right? Lumbars are big bones, right?
Yeah.
Majority of the time it's gonna be a compression style fracture. Agreed? Yep,
Sacrum
jumping.
won't fuse until you're 30 years old. That was that in the Bible, sorry.
Don't fuse until you're 30,
Yeah.
So,
roughly.
So we have
I mean,
like half the class.
yeah, half
Their
of them.
sacrums aren't even fused
Half of
yet.
them, like,
Oh,
half of
that's
them,
like Freddie on,
That's
like,
cute.
Fontanelle.
It's
No,
like,
you
yeah,
have
it's
such
like,
a
hey, they're still
cute
babies.
sacrum.
Still babies. Right? And then, I mean, just imagine how easy it's gonna be for them with their sacrums, or with their coccyx, right? You got a whole nother 30 years for your coccyx as well, right? So, I mean, it could be really, really easy to fracture those, right? Alright, so we got those. Alright. Your ribs, thoracic, are they all the same?
No.
Are they all anchored?
No.
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 They're anchored somewhere, right?
Yeah.
Oh,
They
yeah.
just don't totally float,
I'm one
but they're
end.
anchored somewhere, right? It was a trick question, I got you all. Okay, so how do the ribs work up on top? How are they connected? Talk about the spine first, and then we'll talk about the front.
They're attached to the back of the spine, and then they're also attached to the sternum in the front.
Okay, so they're attached to the spine, right?
But it's cartilage via that.
Spine.
Maddie, okay. Oh, see, and Maddie even smiled when she gets credit for it. There it is. Oh, now she's turning red. Oh, geez. Okay. Okay, so it's attached by cartilage in the back, right? So once again, when you run your hand down the side, like I was telling you, Justin, hop up for a second for me, please.
Oh.
No, you go ahead, do it. Do it.
He was like, yes.
Oh. That orca.
Okay, so as you're palpating, hey James, right up, buddy. As you're palpating, right? So you're running down, and so at the same time as you're running down like this, what am I doing with the rest of my hands?
Feeling his ribs.
Right? I'm feeling the rest of the ribs because I'm checking like as I push here, I'm not like pushing with the outsides of my hands. I'm pushing down here, and I'm feeling for any sort of, when I push here, does it push out on my hand, right? So basically that would show that there's a potential of a flailed segment, right? If I haven't witnessed the paradoxical movement, so I'm just like, ooh, I push here and it pushes out on my hand here. Am I gonna spend a little extra time now? Yeah, I'm gonna move back up and say, hey, did I miss something up here higher? And I'm just gonna run myself down, pushing like that. All the way down, it's like, oh, okay, no, I shouldn't have any ribs down here, right? So I should be good to go. Yep, all right, move back up. Okay, and then now I'll run down midline. All right, thanks for not, on your feet, standing up.
Excuse me.
Okay, so upper portion of your thoracic cavity is all anchored pretty well, right?
Yeah.
Yeah? Takes a lot of force to fracture ribs, right? Not a lot of force, it just takes isolated blows and you can fracture a rib pretty easily, right? But knowing that you're anchored in both the anterior and posterior portion of the body, right? There's not a lot of flex to them, right? So if you do take force or trauma, you have the potential for fracture. Is it more of a mid-rib fracture, or do you end up fracturing at the sternum or at the spine?
Depends where the trauma
Point
is.
of the contact and the thing.
Right, so a lot of times, it's very rare that you'll see fractures along the spine. And so, majority of the time, it's gonna be like, almost like a mid-shaft, because that's the weaker portion of the rib, all right? And so, as you're palpating, you're constantly feeling, you're pushing to see if you're getting any sort of additional movement, crepitus, anything like that on the palpation. Hey, did you need something? Or are you just glad you made it?
I am, I'm so covered in mud. I had a couple of dogs find their way to my house, and I had to wrestle them for a while.
Oh.
You had to wrestle them for a while?
Yeah.
That's the terminology.
All right, so your first 9 are attached, right? And then what happens at the bottom of the rib cage? What happens?
They're not as well secured.
Not as well secured, right?
9 through 12.
Technically, right?
They're attached to each other.
So you have longer, there's less protection, right? So how are they connected to the sternum?
Cartilage.
Okay. So do you run do you have more cartilage on the lower portion than you do up above, right?
Yeah.
So basically you have a small portion of cartilage on the top, and you have these long amounts of cartilage towards the bottom. Yeah? What's easier to break, cartilage or bone? Why?
Because cartilage flexes.
Yeah, because cartilage has a little give to it, right? So if you're going to break something, where's it more commonly going to be?
Where the bone connects with cartilage.
Cool. So do you have the potential for tearing off where the cartilage and the bone connect on your floating, less connected ribs?
Yeah.
Yeah? So that's the type of injury pattern that you're going to have for your lower portion. A lot of times you're going to end up snapping off like the very end of those bones, right at the end. Like if you palpate and feel, right? You can kind of feel kind of the floating portion of them. Like snapping that little end off is something to be concerned about. Oh yeah?
Oh, yeah, I just saw them this weekend.
Oh yeah. There's games. Oh yeah.
Well, and the thing was, is you couldn't tell that there had been any real injury there until they did the X-ray. And then we found out that part of it had gone right into his lung.
Yeah, it's amazing how hospitals can retroactively find cool stuff. They'd be like, oh, there's nothing wrong with this person. They sat in the waiting room and then they sat in a class or sat in a bed for 2.5 hours, and then, oh, we're gonna send you in for an X-ray and be like, oh, hey, you're a trauma activation and we're putting you in and you're gonna go in for surgery, right? Because they have all the X-rays and CTs and stuff like that, right? What do we get in trouble for if we miss something?
Really? You missed that?
I know, right? Yeah, they're like, how could you miss that? Mechanism right there shows exactly that you should have been suspecting that. It's like, really?
And they didn't until they did the X-ray.
Right, right.
They didn't know until.
Oh, I would love, see, I always offer people, like, anyone who ever questions what I do, I'm like, hey, just come spend one day with me. That's all I want you to do. Just one day, like at my station, like, just come hang out with me. Like, my old man, he's a paramedic down in Reedsport, right? They run like, I don't know, 4 or 5 calls a day, maybe on like a good day, right? And he's been a paramedic for 30 years, something like that. And I'm like, oh, I was like, hey, how's your day? He's like, oh, yeah, we've been very busy. I'm like, oh, you had 2 calls today? He's like, ah, funny. I'm just like, dude, like, just go spend one day with me, please. Like, I'll work a medic overtime special just to have you come ride with me, just for one day. Derek, I've been trying to get Derek to come ride with me. I'm just like, he's like, oh yeah, we got these transfers in the middle of the night. I'm like, oh yeah, that sucks. I was like, oh, so you had 1 call, right? He's like, yeah, just go spend one day. That's all I want you to do, right? Same kind of thing with nurses and stuff like that. They're like, oh yeah, okay, yeah. Got this person on the car, yep, okay. Hey, what's their blood sugar? Hey, what's their temperature? I'm like, sorry, I was intubating them and doing a bunch of other stuff. I really apologize. I didn't get that. I'm sorry that the Pulsar app didn't really work for you, and I didn't send it the right way, and I didn't put the right information in there. Sorry, I was ventilating this person, you know, really like doing something. I didn't have to call the doctor.
You didn't have RT come down?
I know, right? Man, that's really fired up about that. It's funny because you guys are now in the ER, and so you're seeing some of this stuff. And so, yeah, man, there's nothing that makes me angrier than just nurses in general.
Get it out.
Yeah, so, speaking of ER, you guys need to do a better job of when an ambulance comes in and you guys are just standing around not doing anything, you need to go listen to those pass-offs that are happening. I've witnessed multiple people in there because I worked a couple overtimes. I'm not going to point any fingers at anyone. They know who they are that I've seen. But yeah, you guys got to get a better job of getting into the ER when that pass-off happens, because that is what we do as paramedics. Those are the pass-offs. That's the information. And what you need to realize is you need to realize that those nurses aren't listening at all, ever. And so I really have fun sometimes where I'll just start making stuff up as I'm just talking. I'm just like, oh yeah, this person jumped off a 500-foot bridge, you know, did a swan dive, yada, yada, yada. And you're like, yep, what's the patient's date of birth? It's like, oh, yeah, okay. Yeah, they were born in 1822. All right, 22, yep, got it, okay. I was like, right? But you get to hear what the paramedics are saying, that information that pass off, so you hear what's important from the pre-hospital setting versus just like roaming around, not doing anything. Like I'll see some of you, I'll be like, man, I'm like, ooh, like, hey, I see you, I know you don't see me, let's see what happens. And I'll go around the corner and I'll kind of hide, and I'll be like, oh, weird, we just gave a full pass off, and ambulance came in, and I was like, oh yeah, no paramedic student showed up. Classic, right? I'm always watching, right? I've already had crews talk about some of you. They're like, hey, what's up with blank, blank, blank? I'm just like,
Blake.
blank, blank. Right? And so, yeah, people are always, I told you guys, like, people are always, like, feeding me information and talking and stuff. Some of you have gotten some pretty awesome reviews. Some of you have gotten some can improve skills kind of thing. Yeah, just know that you guys are always being watched all the time there. All right?
You can improve skill reviews from other paramedics?
And from some of the nurses.
Oh, okay.
Yeah.
Because the paramedics, we don't really interact with paramedics that much.
Right, and that's your guys' fault.
Did you just admit that?
You just set yourself up. Yep. Just like, hold on. And here it comes again, right? So that's exactly it. So like, you guys should be interacting with those crews, and as they come in, like, you kind of meet them. You meet them at the door, like if you aren't doing anything, and be like, hey guys, hey, what's going on? I mean, maybe not at 2 or 3 o'clock in the morning, because they're not gonna like the happy chipperness. But like during the day, like yeah, like follow them in, listen to everything, ask them questions, and you guys, most of the paramedics out there, I mean, they've been in your shoes, and they like to help and teach and do that kind of stuff. Not at 2 or 3 o'clock in the morning. They probably will say like 0 words to you. But that's the approach to take, all right? All right, so some of your palpation, right? So you got your C7, right? C7, T1. So everybody grab your partner next to you. Find C7. Some people are very prominent, and some people are not. So, okay, so listen. So take a quick second now and find C7 without them putting their head down, because they're having to hold C-spine. Because hey, let's just do a little C7 palpation here. Well, oh wait. So now they're paralyzed because you made them put their chin to their chest.
Oh, right here.
James, it doesn't count. You gotta find somebody else's. You gotta find somebody else's.
Right there.
Okay, is anybody having a hard time finding? Is there anybody that is not a real prominent C7? Everybody's pretty prominent?
Apparently I'm hard.
Are you deformed? Alright, everybody head over and check the non-prominent. Touch Allie. Everybody go head over and touch Allie. If Allie doesn't mind. Allie, do you mind? Okay. Everybody get in line. Everybody can find the easy one. Oh, dang.
Palpate spines.
These are our portraits of you, Kris.
Huh?
Absolutely.
There's a hoodie.
Oh, the hoodie. Hoodie's good every time.
Right there, huh?
There it is.
Nailed it.
Yours is prominent?
Can I feel your spine?
Of course.
Right?
Hey Blake.
Kris, when's your next medic shift?
The next medic shift? I don't know.
I saw you and Sahali like within like 10 minutes of each other.
Did you?
Friday.
Let's see. Friday. Oh, yeah. Yeah, I work Friday. UD. You're at UD. No, you're Mackenzie. Okay. Yeah. And then we went in and we dropped our patient off, and there was no Sarah anywhere.
You can name it.
I know.
I bet you it's like,
Busy.
That's always the excuse. Oh, I had to go to the cafeteria to get some food and take my break.
Oh, yeah. Get in there. If anybody else says Sarah is horrible, I want to know though.
Oh no. They should be giving you horrible reviews.
Yeah.
No, I give like 1.
Well,
Yeah, we have options.
You realize one's
My
are
very
bad,
first-
right?
my very first shift, she did
It's
say
1
like
or 0.
needs to work on IV skills. Like I got that.
No,
That was good. But I knew it. It's not nothing I didn't know. Huh?
that woman you brought in, Kris, was awful.
Yeah.
Which one?
The DKA one.
She was sick.
Yeah, her blood sugar was 1,500.
Yeah, it was over. We knew it was over 600.
Yeah.
Yes, that was a great case. So let me explain. I'll talk about that here in just a second. Somebody else have something?